This course and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2024, all rights reserved. Good afternoon, my name is Chris Piccuito. I'm the Assistant Director of Respiratory Care Services at Mass General Hospital in Boston, Massachusetts. Welcome to today's program, Bronchodilator Efficacy of High Flow Nasal Cannula in COPD, Vibrating Mesh Nebulizer versus Jet Nebulizer. Upon completion of this AARC webcast, participants will be able to understand the study design, protocol, and statistical analysis, distinguish how the non-inferiority analysis employed by the authors differs from the traditional analysis that the readers may be familiar with, understand the results, the author's interpretation, and how the editorial compares to the author's interpretation. I am pleased to welcome Gregory Burns. Greg is a respiratory clinical specialist at the University of California Medical Center, San Francisco, California, and adjunct faculty in the Bachelor of Respiratory Care program at Skyline College in San Bruno, California. Gregory's research interests are in acute respiratory distress syndrome, critical care, and mechanical ventilation. With a master's degree in clinical research from UCSF, Gregory's academic interests are in epidemiologic methods, biostatistics, computer science, and machine learning.
All right. Thank you for the warm introduction, Chris. Nice to see all of you. Figuratively speaking, there are about 373 of you out there. That number keeps climbing. If I know you, nice to see you. If I don't know you, nice to meet you. I'm very pleased to present the February Editor's Choice manuscript to you today as part of this JournalCast. Now, we're going to approach this manuscript from the perspective of the study design, the analysis interpretation, and I hope that you enjoy this and that it helps you kind of understand research methods, analyses, and kind of the whole research process. So we're going to set the stage by discussing the background to this research question in order to really understand the study and why the study is important. We're going to look at the research question and in detail discuss, why is this question relevant? Why should we even ask this question? Why should we even do a study to investigate this question? The authors of this study employed a very novel design by using a non-inferiority study. And so we're going to look at that study design. We're going to look at the materials, the methods, and the measures they use. We'll look at the results. We'll say, what are the key findings? We'll look at how they interpreted it. And there's an editorial published along with this in February. And we'll see what are the key points that the editors or that the authors for the editorial made. All right, so let's set the stage. Let's look at some background and let's look at the research question. Now, the star of today's show, in a sense, is the high flow nasal cannula. So as you know, these are devices that are pneumatically or turbine driven. They can deliver a lot, they can deliver a little to a lot of oxygen or gas. They typically have a heated humidifier and a circuit with nasal interface that allows the delivery of flow. They're typically blended, but not necessarily, but they all can deliver flow rates that meet or exceed a patient's inspiratory demand. Now, we're going to be looking at high flow nasal cannula in COPD for medication delivery. But before we get there, let's look at high flow nasal cannula in COPD. Now, as you probably know, especially after the COVID pandemic, heated high flow nasal cannula has shown potential benefits in acute hypoxemic respiratory failure and in the prevention of extubation failure. Now, some of the physiologic benefits which may especially pertain to this COPD patient include the washout of airway dead space, facilitation of secretion clearance, and counterbalance of autopee. In a previous study, high flow has been shown to reduce the rate of severe exacerbations and improve health-related quality of life in subjects with stable COPD. As you probably know, aerosolized medication delivery is a standard in COPD treatment, especially for the delivery of aerosolized bronchodilators. Now, these aerosolized medication are typically given with a jet nebulizer and aerosol mask. And you may ask, what about using jet nebulizers in line with a high flow nasal cannula? Now, that is possible, but the additional gas from the nebulizer, which you're introducing into the circuit, may alter the delivered FiO2 and may pressurize the high flow system in a way that the system's not designed for. Now, vibrating mesh nebulizers may offer a clinical benefit in COPD. These are devices, if you're not familiar, which are electronically driven, so not pneumatically driven, thus requiring no additional gas flow into the circuit. These offer a smaller particle size, which can improve lung dosage, and for any given dose of medication, it'll nebulize more of it, resulting in a lower residual volume of the prescribed dose. Now, when we're looking at vibrating mesh nebulizers versus jet nebulizers in COPD in the context of non-invasive ventilation, the authors for the study that we're referring to for this month's Editor's Choice, they refer to two previously conducted studies. One of them, by Avdiv and colleagues, looks at 30 subjects with acute COPD. They enrolled these subjects after they were clinically stable. They compared vibrating mesh nebulizers to jet nebulizers, and they noticed some improvements. They noticed that these subjects with the vibrating mesh nebulizer had higher PFTs, or pulmonary function measures, such as FEV1 and FVC, the forced expiratory volume in 1 second, and forced vital capacity. They noticed that after the vibrating mesh nebulizer, that these subjects had a lower respiratory rate compared to jet nebulizers. They were less dyspneic, and they had lower arterial CO2. Mind you, this is in the acute COPD population. Other study that the authors for our Editor's Choice paper bring up in kind of justifying their study is one by Galindo-Filho, in which 9 subjects with stable, moderate to severe COPD, so these were stable subjects, where they gave them NIV with vibrating mesh, did some measurements, then gave them bronchodilators with jet nebulizer. So this is a single dose crossover study. And they noticed that for any given patient, they had an increase in lung dose delivery with the vibrating mesh nebulizer when given in using non-invasive ventilation. So we're starting to see that there's this body of evidence for COPD in which the nebulizer type can make a difference. But mind you, this is specifically among COPD patients, both acute and stable, receiving NIV. Now, what about looking at high flow with vibrating mesh nebulizers? Now, high flow with vibrating mesh nebulizers has recently been shown to be, and here's this term, non-inferior to face mask jet nebulizers. In this article by Reminiak, which is cited quite a bit, they wanted to compare albuterol delivery in 3 configurations. Number 1, regular face mask jet nebulizer. Number 2, high flow with a vibrating mesh nebulizer. And number 3, just a high flow. Now, this is a very interesting point here. They selected subjects who had reversible airflow obstruction, defined as subjects with an FEV1 FVC ratio of less than 70%, who had a positive bronchodilator reversibility test. Now, just want to point that out because this is not, the subjects were not stable COPDers or acute COPDers. These are people with reversible airflow obstruction, which is a pretty broad population. So they gave one of these interventions, they gave the intervention in random order, and they assessed pulmonary function afterwards. And they found that the FEV1 increase post-albuterol intervention for any of the given albuterol interventions, that increase was similar, suggesting that, according to the authors inferred then, that high flow with vibrating mesh nebulizer is not worse or is comparable to standard face mask jet nebulizer. Now, for us who are interested in managing COPD patients, this provides us with some important information, but the population that this was investigating was not necessarily the COPD subjects that I'm interested in my hospital. So what the authors did is they devised a study. Now, I bet this is their research question. How do aerosolized bronchodilators affect pulmonary function when given via high-flow nasal cannula vibrating mesh nebulizer versus jet nebulizer in subjects with stable COPD? And I looked up my use of affect here, and this is correct. You affect, something can affect something and not effect something. So I just want to point that out there. Now, in terms of appraising a research question, and typically this is done as you're developing your study, you may apply what's called the finer criteria. Now, the finer criteria looks at the different factors involving a research question. Foremost, the research question, is it feasible? Now, looking at the research question the authors, I believe, employed, previous evidence suggests that albuterol delivered via high-flow vibrating mesh is similar to jet nebulization. The previous study that we just looked at, it shows that vibrating mesh versus jet neb in subjects with reversible airflow obstruction is non-inferior. So is this research question we're looking at for the study, is our research question even feasible to investigate? Based on the previous evidence, I believe it is. Now, the I is interesting. Is this an interesting research question? Why should we care? If it's not interesting, why should we do it? Why would anyone fund it? Now, high flow use has shown a clinical benefit in COPD, right? So high flow alone. Now, integrating it with aerosolized medication would be advantageous. It would be a very clinically beneficial thing for us to know, because it would be a clinically beneficial thing for us to potentially do. Now, novel. Is this research question novel? As mentioned, the previous study by Romaniak was in subjects with reversible airflow obstruction. So these comparisons, vibrating mesh high flow versus jet neb, have not been made in subjects with stable COPD. So this research question is novel. It has not really been looked at in the past in this particular population. E is for ethical. Is it ethical for us? Is this research question ethical? Now, for our research plan, we can address this by performing a non-inferiority study, which are quite common in studies in which you cannot withhold medical management. You're not going to give well, in this case, it's with stable COPD, but it would be theoretically unethical in certain patient contexts to give a placebo versus a medication. And is this research question relevant? Yes, I believe this research question is very relevant because high flow has gotten a lot of press lately. It's a lot of great research for high flow coming out in the last 5 years, 10 years, and so has vibrating mesh nebulizers. We're seeing more and more vibrating mesh nebulizers on the market, coming plumbed on ventilators from manufacturer. There's a lot of attention being paid to both of these two topics, so naturally integrating them together is quite relevant. All right, let's go into the meat and potatoes for this study. What did they do? All right, this is a randomized, non-inferiority crossover study. Now, what they did is they randomly assigned subjects in blocks of 4. What this means is that for every 4 patients, they randomly assigned out of the 4. So there's 2 treatments, which means that you would randomize out of those 4 people, 2 people to treatment 1 and 2 people to treatment 2. So blocks of 4 randomization, and they were randomized to the first treatment type, whether that being high flow nasal cannula with vibrating mesh nebulizer or jet nebulizer. So they were randomized to the first treatment. And randomization is important in the research context because it ensures the equal distribution of confounders, which are things that could be associated with the subject receiving the intervention. For example, maybe as I'm assigning this particular patient, high flow versus jet, I might be biased to give this particular patient the high flow first, or this particular patient the jet nebulizer first. So that variable is associated with potentially both the intervention and the outcome. So randomization helps ensure the equal distribution of these confounders. Now, you can see here that the patients were assessed for, now I'm looking down the flow chart because I know you can't see my mouse. So patients were assessed for eligibility, enrolled, and had a baseline PFT performed. Then they were randomized. From there, they received their first treatment, had PFTs performed, and then the crossover occurs. Now, the crossover occurred, and the crossover being given the alternate device. So if you received the jet nebulizer first, after a 4-hour washout period, you would receive the high flow nasal cannula with vibrating mesh nebulizer. So the crossover would occur, and it would allow them to measure the effect of the intervention using both interventions in the same subject. So this is a randomized non-inferiority crossover study. They used salbutamol, which I Googled and learned is albuterol, 2.5 milligrams, a short-acting beta agonist. They used a Fisher & Paykel Airvo 2 high-flow device at 30 liters per minute at an FiO2 of 0.3. And they used a vibrating mesh nebulizer made by Aerogen called the Solo. That was the intervention, so to speak, and the control, or the standard of care, were a jet nebulizer driven off of 6 liters per minute of oxygen. So, in a little bit more detail, we're going to look at the measures they took. So, the investigators were interested in looking at bronchodilator efficacy, which is the ability for pulmonary function to improve from baseline to post-treatment. So they wanted to compare, and if you look at the left red line in box, they wanted to compare the difference between post-jet neb bronchodilators, the difference between that and baseline, versus, if you look at the bottom right box now, post high flow nasal cannula bronchodilator against the baseline PFTs. Now, the spirometry they conducted according to the standards deemed by the American Thoracic Society and European Respiratory Society. This study was performed in Thailand, so their PFT measures included reference values for the Thai population. And very interestingly enough, they also use a device I'm not familiar with, which I'm sure many of you are. It's called impulse oscillometry. And this device was made by a company called MasterScreen. And they made these measures for these iOS measures according to the standards by the European Respiratory Society. Now, impulse oscillometry, I might be saying it wrong, is very interesting. And what it does is it allows you to measure lung mechanics during quiet tidal breathing. It allows you to measure resistance and reactance. And this is done quite often in conjunction with standard spirometry PFTs. Now, what's really interesting is that with this iOS, it applies these oscillating pressures at different frequencies from 4 to 50 hertz. And the measurements at different hertz relate to airway resistance and airway resistances at different levels of the trigger bronchial tree, where at lower hertz, the resistance or the signal that's being measured reflects the total airway resistance. And at higher hertz, you're able to look at the large airway resistance, and the difference between the two is estimated to be the small airway resistance. So it can be useful in peripheral airway disease, where you can differentiate small from large airway obstruction, which is especially important in COPD, where we're looking at peripheral lung disease. So I found this to be very novel, and I think it's a very interesting way to look at this research question because it allows you to look at the physiology behind what's happening. Now, in this study, the primary outcome was the absolute change in FEV1. And as I had shown you, it was between those two time points. It was between the post-jet neb and baseline and post-high flow vibrating mesh neb and baseline. That was the primary outcome. Secondary outcomes include the absolute changes in these other PFT values, including the spirometry values, lung volumes, these iOS volumes, which include what I had just mentioned in a previous slide, the resistance at 5 Hertz, resistance at 20 Hertz, the resistance between 5 and 20, AX, X5, and FRES, which I'm not entirely sure of. They were also interested in looking at nebulization time and cataloging adverse events. Now, in terms of the accessible and target population, and the target population being the population the investigators were hoping to sample from, the target population were adult subjects with stable COPD. Now, the investigators were able to sample from this accessible population, which were subjects in Thailand at the Suraj Hospital in Bangkok between June 2021 and February 2022, among subjects who were at least 40 years old with GOLD diagnosed COPD. These subjects had irreversible airflow obstruction. Their post-bronchodilator FEV1s showed an increase of less than 200 milliliters or 12%, with a post-FEV1 of 30 to 80% predicted. Now, to ensure that these stable COPD subjects were in fact stable, they had no history of exacerbation or respiratory infection in the last 4 weeks. These subjects were not pregnant, and there were no contraindications to PFTs. Okay, so this is who we're looking for, very specifically adult subjects with stable COPD. All right. Now, I mentioned the fact that we were doing this non-inferiority study. Now, we're quite often used to looking at testing whether or not a treatment is better than another treatment. So hypothesis testing can be used in this particular context of seeing if something is better than something to see if two distributions are different. For example, on this plot here, these two bell curves are histograms. These represent these samples. And what I want to show you here is that the blue bell curve is different than the red bell curve. Now, let's say the red bell curve was a measure after an intervention. And you can see that the red bell curve is farther to the right. The measure, the mean, the center of that distribution is greater. So in this case, what we're saying is that, well, the intervention resulted in a higher measure than the control. You would use a statistical test or a hypothesis test to indicate how likely what we're seeing is actually valid. I don't want to say true, but how likely this is valid. And this is where you get p-values. And so when I'm looking at this plot right here, I might say, oh, the mean value for the intervention, the red bell curve, is greater than the control. The p-value of less than 0.05. Boom. So typically this is how we think of things in terms of saying one thing's better than the other. What we do is we think in terms of hypothesis testing and p-values. Now, in this study, they did something a little bit different because they did a non-inferiority study where their aim was not to determine if one thing was better than the other or if one thing was in effect different than the other. They were interested in determining if this intervention was at least as good as the control by a certain amount, meaning that this thing is not 5%, in this case, 5% worse than the control. So I'm saying it again, this current study was looking at whether or not the FEV1 benefits in high flow vibrating mesh nebulizer were at least within at least 5% worse than the control. They accepted a 5% margin, where if the intervention was at greater than 5% worse than the control, that the non-inferiority would be demonstrated. Now, when we looked at this previous slide, what we would determine is whether or not one thing was greater than the other. With a non-inferiority study, the possible results are that the intervention is inferior, the intervention is equivalent, or superior, or non-inferior. So you really only have two different options for your results in a non-inferiority study. Now, the sample interpretation for a non-inferiority study would be, for example, that the mean values for the control and intervention, the mean values between the vibrating mesh nebulizer high flow and a jet neb are similar, so the intervention is non-inferior, and so this is what we'd be hoping for. The mean values are similar, so the intervention is non-inferior, or the mean value is greater than the control. If we notice that the mean value is greater than the control, we cannot determine that it is superior. Now, I belabor the point that these non-inferiority studies are different than conventional studies because I think it's important that when we read non-inferiority studies, that we acknowledge that the conclusions are very different than how we typically look at determining whether or not something's better than something else. So, the authors did a power calculation, and what they found is that they needed a sample size of at least 16 subjects. Now, to interpret their power calculation, we say that they had 80% power, which is standard. When you do a power calculation, you're looking for 80% power. That's standard. It's like a p-value of 0.05, 80%. So they had 80% power to detect a 5% non-inferiority margin, only needing a sample size of 16 subjects. Now, they reported continuous variables as median and interquartile range. Mind you, they use the median, which is the middle value, and not the mean, which is the average, because with small sample sizes, you might have more outliers, and medians are easier to handle outliers. And interquartile range is looking at their spread around the median. They make before and after treatment comparisons using this Wilcoxon assigned rank test. And this is a test that you would use to look at a change in a subject pre and post within a subject. So it's assuming that the measures are in the same subject. That's what that's all about. So they're saying before and after in this one subject, we're using this test to take into account potential variance in that one subject. And then they use the Mann-Whitney U-test for between group comparisons because they're essentially two independent groups. Interestingly enough, they also performed a statistical test for interaction. And what they did is they fit a linear model accounting for repeated measures. And what they wanted to see was whether or not their observations were based on the order of the intervention. They used this test to say, hey, is what we're seeing because high flow is given first? They're trying to parse out whether or not the treatment order had a influence on what they're observing. And due to the non-inferiority design, they're providing the standard of care and they're providing a kind of validated intervention. They're not withholding care to the subjects. So in terms of ethical considerations, it seems that there are no ethical considerations in the study. All right. So the authors, and I'm looking at this subject enrollment chart here. So the authors assessed 43 subjects for eligibility, enrolled 17. You can see here, looking down this subject enrollment chart, that 8 were assigned the high flow vibrating mesh nebulizer first. 9 were assigned jet nebulizer first. You can see where the washout and crossover occurred. These subjects had a median age of 72, the median 30-year pack year smoking history, with a 47% FEV1 to FVC ratio, with a 54% FEV1, and the majority were male. So these subjects had COPD. They were mostly male. They were in their 70s, and they had quite a smoking history. All right. So they did two comparisons here. They measured two things here. I want to show you kind of in detail. So first off, the first thing we're looking at here is the difference between the baseline FEV1 and a post-treatment FEV1. So what they did here is they took this box right here. They said these are all, each of these boxes are the post-treatment measures, the post-treatment FEV1 measures. And so each box is being compared to, on the left of that plot, the baseline. So if you look at this plot right here, the y-axis shows you that this is the FEV1 in liters, so that's the units we're working in. Now, the left element in that plot is the difference in FEV1 between baseline and high flow nasal cannula with vibrating mesh. The right element in that plot is the baseline measures versus the jet nebulizer. The points within each element represent one subject's measure, and the line connects the two. So each point in line is one subject's measurement. The p-value on the top of each represent the p-value for the comparisons that I'm explaining right here. So the significant finding they had is that the median high flow FEV1s were, well, pretty close to the jet neb one. So I want to say that they were greater than, but we're not going to say that they were greater than. We're saying that they were not inferior. So the FEV1s from the high flow nasal cannula group, the baseline median was 1.18, and it increased to 1.33 for the high flow vibrating mesh nebulizer subjects. The jet nebulizer subjects, from the baseline of 1.18 liters, it increased 1.29. So you can see those two FEV1s are very similar. The p-value of the measure suggests that those two are significantly different. And so from this, we can say that, that these are not inferior. Now, a key thing to differentiate is this comparison here that they made, which is the difference between baseline and which is the difference between the baseline and the intervention measure made within each subject. Now, this is really interesting right here, because what you have here is you have for any given subject, what was their post-treatment measure, what was their baseline measure, take that difference. So if it was 1.33 and 1.18, the difference is, 0.15. So those comparisons, if you look here, were not significantly different. So it's very interesting because based on the analysis you use, and this is the takeaway right here, based on how you do the analyses, you may be drawn towards one conclusion towards the other, because what this is showing is no statistical significant difference, but the other measure does show a significant difference. And we're going to talk about that in a little bit more detail. In addition, they found, and this goes back to the interaction, they found that the treatment order did not change the effect on FEV1. Now, for the impulse oscillometry measures, they found that at baseline, these subjects had high airway resistance. They described it as these subjects having ventilatory inhomogeneity and air trapping. And post-treatment, they found that the changes in airway obstruction and homogeneity were statistically different from baseline. Now, this plot is a lot to look at, but it's very similar to the previous plot. Each element has baseline versus high flow vibrating mesh compared to baseline versus jet nebulizer. Now, there are 4 individual plots. Look at the manuscript, because this is really small on your screen right now, but this is showing the change in iOS measures. It's showing a comparison between high flow versus jet nebs. And you'll see in the dark black, you'll see the median measure. And if you just look at this from afar, you'll see that in general, the effect on the iOS measures between the high flow and the jet neb, they go the same direction. Now, what's very challenging is that the measures, the iOS measures with the high flow vibrating mesh nebs, those measures reach statistical significance. So we can say with some degree of certainty that the high flow vibrating mesh nebulizers did improve these iOS measures. but the differences were not significant in the post-jet nebulizer treatments, and urge caution interpretation because you can't say too much based off non-significance, because it probably means that your sample is just too small. Mind you, we only had 17 subjects. Now, and this is looking at the physiology of what we're seeing here, and I'm going to kind of approach this from the physiologic perspective. So they saw similar increases in median inspiratory capacity between both high flow vibrating mesh and jet neb. Each comparison were statistically significant, and saw a similar decrease in residual volume. Again, statistically significant. So stepping out from the statistics for a second, what are we seeing here? Well, we're seeing an increase in inspiratory capacity. We're seeing a decrease in residual volume. Suggests that you have less dynamic hyperinflation, less auto-PEEP, suggests that the subjects are having improvement in their airflow obstruction. So we're seeing similar effects in the high flow vibrating mesh versus jet neb, which again, going to our research question of non-inferiority, is leading us to believe that there is a similar effect between the two. And again, I want to stress it, if the vibrating mesh neb had a greater effect, we wouldn't really be able to draw that conclusion, because this is a non-inferiority study. We're not trying to see if high flow vibrating mesh neb is better than jet neb. We're not looking for that. We're looking to see if they are equivalent. And we noticed that the high flow nasal cannula vibrating mesh nebs nebulized much more quickly, 6 minutes versus 20 minutes with a tiny p-value. So we're satisfied with that. And there were no adverse events between them both. Okay. The fun part, the discussion part. Let's make all these numbers and analyses mean something. So the authors conclude, the authors state that their main findings are that the high flow with vibrating mesh nebulizer is non-inferior to jet nebs in stable COPD in their ability at improving FEV1 and inspiratory capacity. They noted improved IOS parameters, that high flow with vibrating mesh neb is well tolerated, and had decreased nebulization time. So going through each point, we can conclude that high flow with vibrating mesh is promising in COPD. We know that there's growing evidence that high flow is useful in acute and stable COPD. We know that in acute COPD, that high flow with vibrating mesh nebulizers can improve PFTs versus high flow, but no previous studies had compared high flow to jet nebulizers like how this study did, because the majority of the previously published research was primarily in subjects with reversible airflow obstruction. Now, from this study, now we know that high flow can be used to deliver bronchodilators with vibrating mesh nebs in stable COPD patients. And what I found to be very interesting, very practical, is that, you know, you ask yourself, what liter flow can you use? Well, in this study, they used 30 liters per minute. So it seems that that is an acceptable liter flow for medication delivery in this population, which is adults with stable COPD. And another interesting kind of conclusion, thing to point out is that the iOS measures were very interesting, and the iOS measures, I think, reflect the physiologic effect of the albuterol here. The authors acknowledged that the pathophysiology of bronchospasm between acute and stable COPD are not the same. FEV1 was shown to improve in acute COPD with high flow vibrating mesh nebs. But in this current study, they look more at that physiology with the iOS, and the improvement in the iOS values suggests that in stable COPD, that there may be a physiologic benefit with high flow vibrating mesh. And the reversal of bronchospasm, which the iOS suggests is present, supports why we may be seeing these improved PFT measures. So they really round out the why behind the improved FEV1 by using the iOS, by saying that, hey, reversing this bronchospasm, this resistance, is probably what's driving the FEV1 improvement. It can be difficult, though, because due to the small sample size, it may be difficult to make further inferences. Now, practically speaking, high flow with vibrating mesh nebulizers have probably a high clinical utility. There's a low risk for adverse events. There's a possible added benefit of high flow on the physiology in subjects with COPD. And with a high flow with vibrating mesh nebulizer, you have the added benefit of a shortened nebulization time. So a number of points here about study limitations and next steps. So, you know, when you're selecting patients with stable COPD, there could be subjects who are more stable than others. Especially in a sample size of 17, you may have an unequal distribution of subjects who are the wellest of the well or the sickest of the sick. So, you know, there may be some limitations in terms of subject selection based on the sample size, where you may not have the whole spectrum of stability in COPD present in your sample. That's mostly due to the small sample size. Another limitation is that the baseline PFTs were not repeated immediately before the crossover. Remember, they had baseline PFTs only performed once, but the guidelines consider this 4-hour washout to be sufficient. Now, you know, I think maybe I've alluded to the fact that I appreciate the iOS data, and, you know, I do appreciate the data, but there's an issue with that in which it's difficult to interpret and compare iOS data between iOS devices. So that's something to be considered in reproducing this study using iOS. You'd have to be careful into what iOS device you use, and that can affect the external validity of the study. And as mentioned with subject selection, with a smaller sample size, you're limited as to the analyses you can use, the measures and comparisons you can use, and you're limited as to what other kind of fun stuff you can determine. And so going forward, someone should probably do a larger study to evaluate high flow vibrating mesh on clinical outcomes, since we were looking at physiologic outcomes. The real question is going to be, okay, given those physiologic outcomes, what's the effect on clinical outcomes? So that would be the next step. You need a much bigger study for that. So in conclusion, high flow with vibrating mesh nebulizers in stable COPD subjects improve FEV1. It's well tolerated. Based on what we see here, the authors conclude that it's not inferior to jet nebulizers. We conclude that high flow at 30 liters per minute with vibrating mesh nebulizers can be used to treat bronchospasm in both chronic and acute obstructive or reactive lung disease. And the iOS gives us insights into the physiology behind what's going on, where you might see some reduction of small airway bronchospasm. All right. Now, there was an editorial written for the study by these authors here. And a couple of the interesting points they made is that when you're looking at improved pulmonary function with bronchodilators, it may be useful to also look at systemic absorption, systemic delivery. Now, the iOS measures may suggest improved small airway bronchodilation, and this may be due to increased bioavailability, meaning that there would be potentially systemic absorption of the medication, but you would need to do urinalysis to measure for systemic albuterol absorption. So future studies should look into that. And then again, they describe how the subjects only restricted their study to stable COPD, but that previous studies justify its use in acute COPD. So as a bonus one, I provided my own editorial for you guys here. And my thoughts are that non-inferiority studies can be challenging to design. There are many ways to do them. When you Google it, you look at if you look at the typical non-inferiority analyses, it involves looking at these 95% confidence intervals in relation to the inferiority margin, and there are many schools of thoughts behind it. The authors here did not employ this type of analysis. They used these comparisons of medians to determine non-inferiority, and it just goes to show the challenge in trying to answer specific research questions. You have to take the good and the bad with any given analysis. Now, these non-inferiority designs can afford you a smaller sample size. Remember, their power calculation said they only needed 16 subjects, But what that results in is you only have 16 subjects. So if you wanted to look at other analyses post hoc or after the fact, you're somewhat limited because you have a smaller sample size. But that's not a knock on the authors, because their power calculation justified the sample size they used, which is how they determine the sample size. But despite these points I make, the results are clinically meaningful. I'm excited to go over here and recommend the use of high flow with vibrating mesh nebs for our stable COPD patients. It was a well-executed study, and my hat's off to the authors for conducting it and for completing, and publishing it. All right. Thank you, everybody.
Thanks, Greg. Great job. We did have some questions come in. It looks like we have about 10 minutes or so to answer some questions. One person had a question to kind of clarify about PFT results in diagnosis of COPD. Given the clinical diagnosis for COPD is a post-bronchodilator FEV1 FVC ratio less than 70%, what's the difference between the COPD and the reversible airflow obstruction cohorts?
Excellent question. I'm going to go to the slide that contains what were the reversible airflow obstruction cohort. This was in the Reminiak paper published in 2018. They, in their subject selection, they just stated reversible airflow obstruction, and these were the thresholds they used. They did not specify COPD, so they would use all comers who met this FEV1, FVC, and bronchodilator reversibility test. So they were very broad in their subject selection, where the current study we're discussing was specific for stable COPD.
Okay, great.
Who did not have bronchodilator reversibility, as stated right over here, who had irreversible airflow obstruction with more limited post-bronchodilator. So that the Reminiak paper was looking at everybody with airflow obstruction. This paper was specific to stable COPD.
So these patients, even after, in a typical PFT, even after getting bronchodilator therapy, didn't have reversible airflow obstruction?
That's correct.
Okay. All right. Let me see. Another question. This person made an interesting point about the brand of the jet nebulizer. Yes. This study was done in Southeast Asia, if I remember correctly. So the question is, what brand did they use? I believe there is a large difference in the quality of jet nebulizers depending on the brand, and then breath actuated versus continuous flow, et cetera. So do you have any comments on that?
The authors use, it looks like they used the most generic Acorn jet neb you could use. They did not use a breath actuated nebulizer. They did not specify that they were using a more specialized brand of jet nebulizer. So we assume then that it's just the basic, 89-cent, version.
Mm-hmm. Yeah, we definitely have seen some studies where those devices do not put out very good aerosol compared to other nebulizers, including the Aerogen.
Absolutely.
One person just wanted to clarify to make sure. So these patients from Thailand, even though that the study took place in a hospital, these patients were not admitted to the hospital, correct?
That's correct. They were clearly not saying they were admitted. They specifically did not say they were admitted. So we assume that they were from subjects they had access to. And again, this is a comment for when you write up your paper and your methods, is you might want to be more clear. You might want to be as specific as possible. If this were outpatient subjects, inpatient subjects, we determined that we can assume that they were, we can't really actually determine anything. In the Siraj hospital in Thailand.
Yeah, I kind of took it as they probably had a clinic there and these patients came in because they were all stable. So it did make sense to me that they were probably not admitted to the hospital. And I agree. I think most studies will clearly say that they're inpatient if those patients are.
That's correct. So that'll be it. Because the target population would be different in that setting. That's why it's important to look at accessible versus target population. If you're interested in looking at if your target population are admitted patients with stable COPD, admitted for COPD, that's different than just subjects with stable COPD.
Good point. Another question says, I've read in prior studies not to do a jet nebulizer via a mask over the high flow, basically because the high flow will kind of wash away all your medication because the flow is so high. So I think they just wanted to clarify that. So this comparison is a jet nebulizer alone, jet nebulizer with a mask by itself compared to high flow nasal cannula with the vibrating mesh neb, not with any type of mask already on there or anything.
That's correct. So the vibrating mesh nebulizer was placed in line in the circuit on the high flow, and that was compared to a jet nebulizer. And I'm sorry that this has a mouthpiece, but it was an aerosol mask jet nebulizer. So the question was correct. It was not superimposed on one another.
Okay, that's what I thought too. Another question. So given the results of this research, what do you believe lead to these findings based on what we know about vibrating mesh nebs have been shown to have a deeper deposition, better aerosol particle size. The data did not show a greater efficacy in terms of percentage of improvement. So I think they're wondering, why didn't, we know that the vibrating mesh nebulizers should be more efficient. So why weren't they superior to the jet neb?
That's an excellent question. And the studies, let's look at the title of the paper, or let's look at the methods. This can help convey my point. The authors designed a study to see if they were comparable, not to see if the vibrating mesh was better. So on that note, we do have evidence that with the deeper aerosol deposition that vibrating mesh nebs may work better than regular nebs. So in this case though, they were not looking to make that comparison. They were merely hoping to compare the two interfaces, the two delivery devices, in terms of being at least as good as one another, or I should say the high flow was at least as good. So it's an excellent question, and it's a question that may need to be addressed in a different study, especially in a study that has an analysis that can support that type of comparison, which I assume would require a larger sample. So good question. But the devil's in the details, the nuance is right here and trying to determine non-inferiority.
Yeah, that's a good point.
Because from a purely methodological perspective, if you design the study, said you're doing a non-inferiority study, if you found superiority, even if you found it, you wouldn't really, you would not really want to say you found superiority. You might say something like, oh, we happened to observe that this measure was greater than this one, but future studies designed for this primary outcome and powered for this primary outcome should be conducted. So in terms of like the methodological stuff, this right here, this non-inferiority aim, they held to. And so you kind of limit the inferences you can draw from the study based on their primary aim.
Great. I think we have time for at least one more. This is something I was wondering about as well. But somebody asked, would there be more home use or hospital use of this vibrating mesh with the high flow? And I was thinking the same thing, like where would people do this, right? With a Earvo high flow device, I believe don't have a reimbursement code for home care, so it's probably not used a lot in home care right now. And if it's used in the hospital setting, typically I think we're using higher flows than 30 liters per minute. So I guess where do you think the authors thought that this type of setup would be used in place of a jet nebulizer?
Now, they don't speculate, but I think you bring an excellent point about the reimbursement. And, being brand agnostic, I want to point out that among high flow devices, you have pneumatically powered devices which require a 50 psi gas setup, and then you have turbine-driven devices which only require power, right, to spin a turbine, which is why it can be used at home. So you make an excellent point. Hey, could this be used at home? If someone's on an airvo at home, could they use this? So I don't think that the authors speculate, but I think that in terms of future work and in terms of future kind of like policy and practice, maybe it's viable.
Yeah, I think we're headed that direction as more evidence comes out that even stable patients with COPD could benefit maybe from nocturnal high flow or use of high flow at home. The systems aren't really portable for them now or anything like that, so it would have to be an at-home thing. And it would make it easier for them if they could receive their nebulizer medicines through the high flow. But I don't really know, at least for our region, if these results are really generalizable for most of us that work in the acute care setting. Mostly, and I say that mostly because I think we would, even once our COPD patients get back to being more stable, if they're still on high flow, they would probably be on more than 30 liters. So we'd have to look at other data to see if, I don't remember what the data shows for aerosol deposition at higher flows of like 40 liters per minute.
Yeah, you bring excellent points, especially generalizability, because this study was focused on subjects with stable COPD, not necessarily who are hospitalized. So.
Okay, well, we're right at the top of the hour, so I just want to thank everybody for coming today. Also, I'm just going to get to the right slide here. Sorry, everybody. So there's an upcoming webcast. Please join us for our next broadcast on February 27th, when Katie Burr and Gary Kaufman will present strategic staff management using the Safe and Effective Staffing Guide. Thank you again, everybody, and have a great day.
Thanks, everybody.
Christopher and Greg, thank you both so much. And thank you also to our participants for joining us today. If you are a group participant, please make sure to